ETSU and has previously worked at the VA Medical Center. Currently a contract physician with the Virginia Department of Corrections, and therefore he is going to be speaking with us today about correctional psychiatry in adult male institutions. And I will turn it over to him. Thanks again.
Good morning and welcome. Can everyone hear me? Okay, this is my disclosures. I have no disclosures to make. I don't have any financial interest or arrangement or affiliation with any organization that could be perceived as a conflict of interest. And I wanted to talk to you today about correctional psychiatry. I work in 2 adult male facilities in Virginia with the Virginia Department of Corrections, and they're both maximum security facilities. And I've given 2 previous grand rounds over the past couple of years, and I think a fair criticism of those presentations, they may not have been contemporary or may have been of some marginal interest just in my own original research. But when I was putting this talk together, I had picked up, or I got in the mail, the August issue of Psychiatric Times. I know many of you in psychiatry get these publications. And the headline, I'm sure you can't read it from here, but the headline is "The Treatment of Persons with Mental Illness in Prisons and Jails, an Untimely Report." And this is a 2014 joint report of the Treatment Advocacy Center and National Sheriff's Association. And they point out a number of problems in the crisis treating mentally ill in prisons and the community. And while I'm not going to talk about some of the problems with access to care or the deteriorating infrastructure of what we do, just wanted to share with you 3 points in this report about conclusions about why there's a problem of increasing mentally ill people in prisons and jails. It says the number of mentally ill in jails and prisons continues to climb, and the severity of their mental disorders is worsening. Jail and prison officers feel compelled to provide the hospital-level care that these inmates need, and they concluded that the root cause of the problem is the continuing closure of state psychiatric hospitals and failure of mental health officials to provide appropriate aftercare for the released. And it just concludes in the final paragraph is saying that jails and prisons will continue to devolve and stagnate as warehouses for the mentally ill that provide little more than medication for the most severely, acutely, psychotically disturbed inmates. I really don't have the perspective to comment on some of the problems with providing system-wide level of service to some of the offenders or people in prisons, because I just work in 2 prisons and I'm satisfied with it. I think they have adequate access to care where I am, but I know it's a crisis in other places. So the learning objectives for today, I wanted to you to leave this lecture being able to identify incarcerated persons as a vulnerable population with an entitlement to health care services. We'll go over that towards the end. There's a one of the legal problems or the legal proceedings and lawsuits that health care has been tied to the 8th Amendment as a constitutional right to care, and help you improve suicide risk assessments of incarcerated persons by understanding risk factors unique to this population, things you may miss in doing routine assessment of someone as compared to the community. And I'll spend most of the lecture talking about that, or at least I have a very busy slideshow on that. And help implement safe and effective care without eroding access to care in the correctional setting. Naturally, some of the patients I see are difficult to work with for a variety of reasons, and I'll address that briefly. And identify common practices unique to providing care at accredited correctional institutions. Both of the institutions I work at are accredited by the ACA, the American Correctional Association. In the correctional setting, a lot of people are in jails and prisons. The incarceration rate has gone up over the years, and approximately 2.3 million people are incarcerated in the United States. This rate has remained steady over the years, and this is just from 2012 statistical publication from the Department of Justice, from the Bureau of Justice Statistics, actually. And it breaks down in that study as 1.35 million incarcerated in state prisons, 217,800 in federal prisons, and the rest are in local jails. This is a number that comes up quite a bit and actually may see it on board exams. And to talk briefly about jails and prisons, prisons are generally facilities where state or federal prisoners have been sentenced to be incarcerated for 1 year or longer. They're violent felons. In the system where I work, there are 6 levels of classification, security classification, 1 through 5, and then level S for segregation. The level 1 would be the lowest level of danger or risk to the community, and the not long sentences. Whereas the higher levels, like when you get to 4, 5, and S, these are offenders with very long sentences, or have not been able to behave themselves in the facilities where they started. And at the highest level would be, they hate for me to use the word supermax, but it's a prison where people that may have to be in segregation until they can demonstrate that they're safe to be around other people. Jails or lockup facilities, or facilities where a lot of people are. They could be there for pretrial detention. You could have federal prisoners, state prisoners, and people serving out some of the time they've been sentenced to in jails. I wanted to talk about this particular study from the Bureau of Justice Statistics from September 2006, where they published that more than half, or 50% of all prison and jail inmates had a mental health problem. And that's somewhat misleading, and the main reason I mention it is because this statistic comes up in articles, well, not in that particular article, but in similar articles where they're doing an expose and talking about the crisis in the correctional care and care in the community, and documentaries on prisons being the new asylums. And this study has come up in litigation. So I wanted to talk about some of the problems with methodology in this study. The methodology itself is that within a 12-month period, if an offender endorsed some emotional symptom like depression or anxiety, or had a problem, or was treated for a mental health problem, they entered into the study as a positive survey. There's problems with the survey instrument. It's all subjective reporting. And under the DSM-4, the old DSM, that for a psychiatric diagnosis. So it's, I guess I should have or. Offenders are endorsing a symptom like being depressed or anxious, or were treated for a psychiatric diagnosis. So that's a lot of people. And it's not necessarily reflective of individuals with severe mental illness. That's a much lower number. Or individuals in need of medication treatment, which would be a lower number. So in the methodology, it's easy for an offender to endorse problems with anxiety, apprehension, or depression, sleeplessness, because incarceration is adverse and welcoming. In jails in particular, they're not nice places because they don't want you to come back. They want a person, if they have their experience there and they are locked up, they want them to think about not coming back. Prisons, there might be more privileges, or it might be a little nicer because people are there for a long time. And I wanted to use the word parapraxis in a grand rounds presentation, so I didn't correct myself on this new word or new term that I created. I didn't create a new term, sociopathetic traits, but I thought it was funny, so I left it in there. What I meant to say there is sociopathic traits. So sociopathic traits generally involve impulsivity, predatory behaviors, and chafing under authority and confinement. Another term that I've run across in corrections and working with interdisciplinary professionals is the term criminogenic. I've never seen that word anywhere else except in prisons. But it speaks to the behaviors or some of the characteristic behaviors of people who are in prison, how they adapt. They tend to not be truthful and have some agenda. So offenders are typically stressed by apprehension, sleep deprivation, and I use the word sleep deprivation to contrast the problem of insomnia, because many people, no correctional lecture or talk is complete without talking about insomnia, because no one sleeps in jail or prison. It's very, very noisy places. They want the doctor to give them something to help them sleep, or so they can sleep the time away. They're troubled by the uncertainty of their status, because if they're about to be moved or transferred, they're not going to tell them when ahead of time. Their lack of privacy and the near loss of control over their environment. So briefly, most offenders in custody are unhappy. They become regressed. They become, immature when they are under stress, and complain about a large spectrum of their existence, which can be expressed in a wide range of emotional dysphoria. And just like no lecture is complete without talking about sleep and insomnia, I have to add malingering or making up symptoms, feigning illness. And that occurs even in people with authentic mental illness in prisons. They feel like they're not going to get treated unless they exaggerate some. So in contrast to people with just symptoms of mental illness who appear in these surveys, I wanted to address my work mostly is providing legitimate medical care, psychiatric care to seriously mentally ill offenders in need of medication, just like would in the community. So in compiling a combination of studies, there's a consistent estimate that between 15 and 25% of incarcerated persons have a serious psychiatric condition like bipolar, major depression, or schizophrenia. It's closer to 25% in jails, people there for a shorter period of time. And people with mental illness, and I'll say in another slide, are more likely to do impulsive things and get into trouble. It's closer to 15% in prisons. And between 10 to 15% of offenders in prisons are prescribed psychiatric medications. Maybe more need medications, but they have the right to refuse treatment. They'll say thanks, but no thanks. I wonder what I did. There we go. Wanted to spend some time talking about suicides and suicide risk among offenders. I've had 2 suicides over the past 6 months at 2 separate facilities. And just want you to leave this lecture today with understanding that there are some gaps or blind spots in our screening and assessment of individuals. And we're imperfect in picking up some of the risk factors that could lead to suicide. But that screening is the key to identifying individuals in need of treatment. When an individual comes into a prison, they typically, in most jurisdictions, will go to a housing unit they call classification. So during that classification stage, which may last a week to 4 weeks or longer, the offender will be assessed by a variety of departments, and they will look for risk factors involving their vulnerability to be taken advantage of or preyed upon by other offenders. And they'll try to identify offenders who are at high risk of victimizing other people they're housed with, and looking at people that are relatively low risk and can go to a lower risk facility where they may be able to have a more productive day or do jobs and spend less money in maintaining them during their incarceration. And depends on their sentence. I had the opportunity to work in classification setting because with the budget crisis in Virginia and other states, they've cleared out the regional jails and brought the state prisoners into some of the regular prisons, and they'll set up a pod, and we'll just do classification in that pod. So all the departments in the prison go through the classification process. So while it's a little more work to do, I find it helpful that, that the interdisciplinary team and myself gets to see a wider variety of people. I mostly see violent felons with long sentences, the life sentences and such. I haven't seen that many individuals who are in for less than a year or charged with poaching or traffic offenses and DUIs and that sort of those sort of offenses. So the highest risk for suicide itself is one that, and I didn't write down here, I'll add to it. The highest risk group for suicide in jails is young white males that are intoxicated, taken into custody within the first 24 hours of being booked. And to add on to that, that is without mental illness. There's almost not enough time to screen these individuals, even if you had the services set up to screen them, because they're coming in, say, for example, they come in late at night and they've gotten a DUI or they've gotten public intoxication and gotten picked up and brought in, and they may impulsively take their own life with the situation that they're in. And without mental illness, there'd be no indication to contact any mental health services to assess them. Just a quick story about working in this in the training area of psychiatry and doing my forensic fellowship in Alabama. I've worked in a variety of offices, the public defender's office and the district attorney's office in different months. And I would go to the local jail and see some of the pretrial detainees there, and some of the attorneys would want me to assess them because they're difficult to work with and communicate with. And I had two jail inmates the same day who were on suicide watch. But the jail had been so crowded after it was like after a weekend. It'd been like, I think maybe Louisiana State University had played at Bryant-Denny Stadium or something, so they had to arrest everybody. And they hold them in the jail until they can release them. So they're running out of bed space, and they had these two inmates who were claiming that they were suicidal. So the jail took both of them, put them in safety smocks, and put them in a cell together to watch one another. I don't think that would not meet the accreditation standard, but it was an accredited jail. But that gives an example of some of the problems you run into with staff that aren't adequately trained or not familiar with how to work with or house people who are endorsing suicidality. Substance users are the highest risk group, or higher risk group than non-substance abusers. That's true in the community, but there's so many more substance users that are in jails and prisons as the leading diagnosis. And violent offenders are higher risk for suicide than substance users in general. And this is a Bureau of Justice statistic that kidnappers are at higher risk than all other persons. I thought that was interesting, but I don't know why kidnappers are at a higher risk of committing suicide, except that but it was so distinct that it was different from just the general grouping of looking at violent offenders ending their life. Basic suicide assessment. I wanted to bring in just as a tool, just a very elementary tool, the SAD person scale. Most of you be familiar with the SAD person scale. I don't have it really well written out here. You can see where it says SAD persons, but each of the first letters represents, it's part of a mnemonic you can remember as SAD persons as risk factors of sex. So males more at higher risk than females for suicide. Bimodal distribution with age, under 24 and over 70 years of age being at higher risk. Depression as a risk factor. Hopelessness is a major linked factor within people who are depressed for suicidality. Prior attempts, a prior attempt at suicide, I think it's something like 80%, or it's a very, very high percentage of people who commit suicide have made a previous attempt. Ethanol or substance use problems, history, leads to the impulsivity you see with suicidality, rational thinking loss like delusions and psychosis. I take a a reach and look at poor insight and some other irrational thinking. Those with maladaptive personality traits as irrational thinking, and loss of support system. When a person goes to prison separated from their support system, they can't just see anyone they want to whenever they want to, or have visitors all the time, and what they've done to get into prison may have alienated their families. An organized plan is dangerous, and having no significant other, like no spouse, being divorced, or widowed, widower, and illness. And when we talk about illness like sickness, is chronic illnesses or terminal illnesses like cancer and HIV or AIDS. So with screening, other than using the SAD person scale, which covers all the major factors with that are risk factors for suicidality, lots of clinicians, even staff, can be trained to use screening instruments or follow a screening protocol in jails and prisons. Just wanted to briefly or mention that in most correctional settings, there are mandated intervals in which the interdisciplinary team or qualified mental health professionals and social workers, psychologists who are assigned caseloads will see offenders who have a mental health diagnosis, like depression or bipolar. They're like in my system, there's 0 through 4 scale. 0 being no mental illness, no endorsed mental health problems. 1, mild symptoms of mental illness but not taking medications. Level 2 would be taking medications and moderate illness. 3 and 4 would be some level of severely mentally ill impairment. So every 90 days I have to see patients that are taking medications, and the qualified mental health professionals have to see them in a similar time frame. If a person's in a segregated setting, that is, they're in a cell by themselves and have very little recreation time and are not allowed out of their cell but about 30 minutes a day to shower or go to recreation, they have to be seen every 30 days. It seems like they change the name every month or every year what they call this kind of setting. They will not call it what it is. It's solitary confinement. But they call it names like restricted housing, segregated housing, special housing, secure housing. It's solitary confinement. And even with that, they still have privileges and rights that they try to get them out. I can say that because some people do belong there for some length of time, and part of my work in both facilities is to work with the severe or seriously mentally ill offenders to get them out of segregation, to help stabilize them so they can participate in the programming that will transition them back to the general population. You cannot screen for bad news. Many suicides that come along unpredictably relate to bad news. A person will go to visitation, or they'll receive a letter where they've lost support from a family member, or a girlfriend breaks up with them, or there's some interpersonal disruption that you don't know about, or they might have to go to court and there'll be a bad outcome, like they get more time or they lose all their appeals, and you won't know about it, and they'll act on it. They won't contact anybody. And this will relate to one of the cases I'm going to talk about. So bad news from outside the facility is a major factor linked to offenders completing suicide that are not under precautions. And sometimes this can occur with individuals who are not mentally ill, not receiving any mental health services. So if an offender is endorsing suicide, and this happens quite frequently, we get people who fabricate or pretend that they say they're suicidal, but they're not. They will do enough things like make a little ligature or endorse suicidality in order to be moved. They'll be moved to an adverse setting of precautions with no property, and maybe wear a smock, be in a modified strip cell with razor restrictions or metal restrictions, and be in medical observation until we determine that they're not dangerous. But they may just be wanting to move out of their cell. They may not like being in there with whoever they're sharing the cell with to get out. But we take it seriously. We treat everybody the same. We try to assess everybody individually and meet their individual needs. Some facilities have housing designed for mentally ill offenders, and this can occur at, in the system where I work, it's usually at lower level facilities. So part of my job is to get people stable enough where they can meet criteria to lower their security settings so they can actually go to a mental health housing unit. And offenders are referred for medication management when we discover they have depression or when there's a high likelihood that they're expressing symptoms of mental illness. For the first case, I call him Mr. Cutter. He's a 52-year-old white male sentenced to 70 years for sex with a minor female. I believe maybe life was thrown in there somewhere, like they got life plus 70 years, but needless to say, I looked at his case. I talked with him about it. I looked it up on the internet after we talked about it, and it turns out that he has like the longest sentence, or got the longest time that anyone in a similar situation has been sentenced to in Virginia under some new law. So he would actually be. I'm not an attorney, but this individual may have had some eligibility to have that sentence reduced down, like maybe give him 40 years or 35 years instead of 70 years like everybody else. He would still die in prison, but that was part of his problem, is that he thought, well, they're giving me so much time, I'm going to die in prison, I've got to be here with these bad people. And he's a sex offender, so he try to keep that secret because sex offenders are victimized in prison. They're the lowest in the pecking order, or in the in prisons and jails. This individual had no history of mental illness or treatment prior to incarceration. He had mostly had public intoxication charged, I believe, but otherwise he had not had a history of sex offenses or a history of other crimes. He was a pilot in one of the branches of the armed forces, and I thought it was interesting that he suddenly, when he's incarcerated, he starts endorsing all these symptoms or creating all this history where he used all this alcohol and street drugs and had all these depressive symptoms, and he'd been on flight duty. How could this didn't match together? So he did get hospitalized. He began endorsing depression, suicidal intent, and made numerous superficial cuts on his arms prior to classification. This would be about 2 or 3 years ago when he was first incarcerated. So when we hospitalize someone in Virginia, in the prison system, we have a correctional treatment center in our region. I think for the whole system, it's in Marion, Virginia. So unlike what's expressed in that article I just talked about, I do have access to refer people to inpatient care for involuntary treatment. So this individual was at a lower level facility, engages in these self-mutilating behaviors, goes to the hospital, gets discharged, comes to my place, my facility where I work. So getting charged with institutional offenses, like harming yourself, that you get charged for self-mutilation, and then you get treatment. That increases the level. That's why about half of all admissions to the Correctional Treatment Center in Marion come from me, because when individuals are classified and they go to these facilities, if they misbehave, they've got mental illness and they get institutional charges, that's a way of getting rid of them, or I guess I shouldn't say that, it's a way of just by default, their security setting goes up and up and up, and they get moved to the higher and higher security facilities, and that's what happened with this individual. In his discharge record, I noted he had borderline personality disorder and major depression, and on examining him, I determined that was consistent. He did have a borderline character structure, but he was willing to collaborate with us. He was getting something from it. You know, he was going the mental health route, or talking more, or wanted to participate in mental health treatment in hopes of getting into a nicer place, or a less dangerous place where he didn't have to watch his back so much and didn't have to deal with as many people. I prescribed him lithium, which helped attenuate his self-mutilating behaviors. He didn't cut as frequently, or he didn't cut any after I started prescribing him lithium. Only when later on, when he got some institutional infraction and then made some cuts and went on a hunger strike, and we put him in medical on observation, and then he destabilized off his medication and sent him back to the hospital. When they wanted to discharge him from the hospital, he cut himself to try to prevent that, to show that he was still unstable. You can't send me back there. It didn't work. We took him back. He calmed down, went back to like a single cell housing. I had recommended that he go to housing where he's double bunked, where he's like in there with somebody to watch him. Or it'd be more difficult for him to suicide or complete suicide if somebody's in the cell with him. But that was somebody else's decision. It was the institution decision where to house him. And this individual continued to endorse suicide, and that learned, if I don't say I'm suicidal right now, they won't put me on precautions. But he would tell me that I'm going to kill myself eventually. It'll probably be around a holiday that's meaningful to me, like Veterans Day or Memorial Day or July the 4th. And so I noted all this. He also disclosed an attempt at suicide. He did disclose it was like a hanging attempt, but I asked him, how did you get an anchor point? And he said, he said, I'm not going to tell you that. That would just defeat the purpose of what I'm going to try to do later on. So I brought this to the attention of the team. We didn't really make any progress in improving any of the, there was really nothing we could do as far as changing the architecture of the facility at the time. So 2 months after he comes back from the hospital a second time, it was on a Friday afternoon around 6 o'clock, after shift change, after evening count, when they stop count is when they stop everything at prison, and the officers have to make a round and make sure everybody's where they're supposed to be, and make sure that everything equals the number of people that are in the facility and they are where they're supposed to be, and no one's escaped. And they do this several times a day. So it was right after this, this individual anchored a noose from a bed sheet in his ventilation grate and was able to, he was over 200 pounds, so he was able to lean into, kind of choke himself, and was able to asphyxiate himself. The next security round saw him in there, went in, tried to resuscitate CPR. That continued until he made it to the hospital. The AED, the defibrillation device, automatic one, it indicated one shock, and he got one shock from that, and they thought they might have had a pulse there for a little while, but that went away, and he was pronounced dead on arrival. I started incorporating the use of a safety plan, which I learned about at the VA. This is a crisis plan where patients who are high risk for suicide can manage their own behaviors in an escalating fashion, then contact the clinician or access services in a crisis safely. So it creates a way for patients to both manage their own lethal behaviors and a practical, meaningful way for them to access services when we have people that we know that are going to be high risk every day, and we can't just see them every day. Subjective reporting, I'll just repeat again, the subjective reporting from offenders like this is not always reliable. It's not reliable in his case because he had already stated that he was misleading us, or he was going to not seek help. And just in my relationship with the facility as a consultant, I have to see whoever they want me to see, and I have to see people who are obviously in danger like this. So I had to keep seeing this guy even though he's telling me he's going to do something. He's going to do something. I was giving him lithium, continuing that. He never attempted to overdose or hoard it. He didn't see that. He was smart enough to know that he has got to do something lethal to kill himself. You can't just rely on chance. So the objective data in his chart documented that he was showering, sleeping, swimming, eating, and I just want to impart to you today that objective data is more defensible after a suicide has occurred because it goes beyond what it says. It is a more in-depth assessment of their suicidality and circumstances than just patients saying they're not suicidal and not homicidal. I'm as guilty as anybody of putting that in the chart, but I'm not concerned about the high risk of suicide. I'll put down they're not suicidal. So in using the sad person's assessment scale, we'll look at Mr. Cutter. He was male. He was not elderly, but he was going to be spending the remainder of his life incarcerated as a sex offender. And depression was one of his diagnoses, so another risk factor. He had had prior attempts at suicide, and he had disclosed those. And he had a stated history of alcohol and street drug use. He wasn't psychotic, but I found his expressions or his thoughts or his ideas and poor insight about things as being irrational. So that could be a risk factor, although it wouldn't meet the strict criteria of using the point scale to come up with a number of points on the sad person scale to make some determination or show that you used it to make a determination as to what kind of precautions a person should be on or how often they should be seen. He had no support, and after his death, no one wanted to collect his body. He had a sister, he had 2 children from a previous marriage, and they didn't want to hear anything about him. They didn't want to claim his body. And again, he had an organized plan that he would not disclose. He said he indicated he had an organized plan, but he wouldn't disclose it. Migraine headaches was his most severe health issue. That doesn't really factor into as a positive from the sad person scale, but that was a condition that I was treating. And move on to the next case of suicide. I call him Mr. Orange because he's always wearing orange clothing, because they wear these orange clothes when they're in segregation. So he was a 29-year-old male sentenced to life with no possibility of parole for murder, robbery, and use of a firearm in a crime. And he had come into prison several years ago when he was about 23 or 24 years old. He had a rough circumstances growing up. He was abandoned by his mother. He had used drugs like cannabis, cocaine, methamphetamine while he was on the street, and he was committing armed robberies to purchase drugs. This is his story. And he was always dysthymic whenever I saw him. He was diagnosed with bipolar personality disorder. He had been hospitalized previously. He would cut himself under stress, and if he was double bunked with another offender when he got tired of him or he didn't get along with him, he might cut himself or say he was suicidal in order to be moved. Or another thing that offenders can do is they can say, "I'm in fear of my life," and then they'll move them to a segregated setting. So the system itself, or working with the system rules and policies, doesn't really help a person tell the truth and be honest and forthcoming. They use it to get what they want. He claimed an allergy to all psychotropic medications in order to prevent me talking with him about it, or in order to put a stop to all these trials, because every doctor he would see would always try him on some medication, because we would tell him that, well, you've got anxiety, maybe you should try venlafaxine or fluoxetine. I tried him on, I eventually talked him into using long-acting venlafaxine and escitalopram in another trial, but he insisted both of them stop in the first week. He said, "I don't want to put chemicals into my body," which was interesting because he tested positive for cannabis, and they found cannabis in his property when he was at the lesser maximum security prison where I worked. So he moved to the supermax, or the segregated, the higher level of maximum security up the road. I saw him there, and that's where he ended his life. He was not on medicines, but I had to follow up with him regularly. And this is the part of the lecture where I talk about some systems-based practice as a consultant. Because of a person having rights to treatment and making grievances and suing, as part of the Prison Litigation Reform Act, an offender must exhaust all administrative procedures, all the informal grievances, and all the procedures in place to resolve their problem before going to court. So to pull the plug on these administrative complaints, it was easy enough for me just to schedule him regularly on my schedule, go sit and talk with him and address his concerns every few weeks, or at least every 90 days, same as I would do with an individual on medication. I'd give him the same recommendations. I would try to individualize his treatment, and I thought we were making some progress. So visits with him were typically negative. He was opposition and help rejecting, and had a lot of complaints. But I got to know him, and I felt like I had a good handle on his risk factors. So the final visit was around Easter, and he was upbeat and positive, and I was so eager to embrace his euthymia, and I was glowing at being able to give him the good news that there are now programs he can participate in. We're going to have group therapy and individual therapy, and we're going to meet in the office, and the interdisciplinary staff is going to come and start therapy with you, and there's going to be books and programs and all this stuff. And he said, that's great. I'd like to do that. But I feel like I found balance in my life now. And he denied any suicidal thoughts. And at a previous visit, and this didn't click with me, or I didn't pick up on the fact that this visit was so different than all the previous visits that it could represent something dangerous. But in the back of my mind, I knew something might be up. So I said, well, what about some of your previous statements you made? He said, you're not the kind of guy that's going to ever be in GP. You're always going to be in SEG. And he said, no, I don't think that's true at all. I don't mind going back to GP. In other words, he was telling us everything we wanted to hear, that he wanted to participate in the programs that we had and go where we wanted him to go, or go to a better setting. The next day, this was on Friday, and on Saturday, less than 24 hours later, he covered his cell window, and at least one security check round didn't challenge his window being covered. They would have to stop their security round if they're understaffed, and that's what's going on in there, and still have all these other cells. So they didn't check him, but they checked him the next time. They challenged him the next time because his window was still covered. They went in, they found where he had, it was in the process of bleeding out, exsanguinating. He had obtained and stashed a sharp piece of metal and cut both arms deep enough to produce a significant blood loss. This is a very unusual suicide, in that he had taken measures to choke himself while he was bleeding out. So he was in kind of a leaning position, sitting and leaning over, and he had ligature around his neck. And he died from a combination of asphyxia and blood loss. So 4 days prior to the suicide, we learned later on, after the fact, that he had met with his adoptive mother and came away from the visit very distraught, labile, tearful. Some of the security officers later on said that, oh yeah, they were on duty the previous few days, and he came away from visitation very upset. And so he had gotten some bad news. We don't know what that bad news was, but it really changed his outlook on things, and that's, I think, is when he made the decision to take his own life by suicide. So bad news, again, stressors or blind spots in our capacity to assess suicide risk for offenders. It would just be by accident or just by fortune that maybe somebody would see something and let you know. A couple of questions. I'll go over each one of the stems in the discussion, and I don't like audience clickers and things. I just want you to look at it and think on your own, think it through. A major risk factor for suicide in custody that is not typically screened and may be missed. You have the select diet. Diet is bad. We get a lot of complaints about diet. Bad news from outside the facility, substance use in custody, incompatible partner, and young age. The answer to that is bad news from outside the facility, which we just discussed. As far as diet, no one likes the food they're served, and physicians are typically approached to put allergies in the chart so the person can get on some special religious diet or no beans and that and forth. Substance use in custody. Homemade alcohol is a problem. It's easy to make. I won't go into how they make it, but we're always checking. The security staff are always vigilant to check those, and they kind of know who does this, and they're always looking for it. Substances infrequently occurs where I am, but my understanding is that smuggling substances into jails is commonplace, or it happens quite a bit. And patients or offenders do get intoxicated while they're in custody. Incompatible cell partner is a daily part of life in my practice. I hear about that at almost not every visit, but every day that I'm on duty, I'll have at least 1 or 2 patients that say I'm just not getting along with the person that I'm assigned to housing with. And of course, young age can be screened. The next question that I put in is, patients generally see clinicians as allies until they decide to end their life by suicide. You can mitigate this risk by assessing using the following: the subjective data from the patient, that is the patient saying, I'm not suicidal, I'm not homicidal; collateral data from others, which is always helpful in the initial assessment or initial interview; objective or measurable data, which we discussed; increased frequency of visits to weekly. That's in keeping with what I'd learned or what we had done when I was at the VA, where we identify a person as high risk for suicide and see them more frequently, and use of a safety plan, which is not just at the VA. It's generally an accepted practice in all settings in the community, in the way I understand it. And the answer is objective and measurable data. It's defendable because you can go back and look at it after a person is dead, and you're not getting all the story from a person who is wanting to end their life by suicide and they want you to not stop them. So subjective data from the patient is not always reliable. Collateral data is helpful, but it's helpful when they're alive. The increased frequency of visits helps people who are collaborating and not withholding information. And the safety plan only works when a patient is in the treatment alliance. Insomnia. People say, I can't sleep, I want something. I want something for my inability to sleep. Well, we can't treat everybody. And a lot of people, it's sleep deprivation they have, because jails, prisons are noisy places. They're boring. People just like to sleep. And but it is reasonable to treat sleeplessness as a dimension of Axis 1 disorder, like anxiety, PTSD, depression, or bipolar disorder, schizophrenia. We don't typically use any benzodiazepines or zolpidem type sleep medicines in jails or prisons because they're too easily diverted, and you'd really have people asking for a lot of medicines if we prescribe those very often. One agent to consider if you're ever working in this kind of setting and you run into where they're doing pill passes at 3 in the afternoon or early in the afternoon, not at bedtime, is diphenhydramine. It has an 8-hour, its peak, or its half-life. The way it works is it peaks its sedating qualities at about 8 hours. So it doesn't work very long. People get used to it fairly quickly with its anticholinergic effects, but some of the patients I see, they can take it at 3 in the afternoon and it peaks 8 hours later at 11 o'clock. I want to talk about, in one of the learning objectives, about patients having an entitlement to treatment when they are incarcerated. It is because they're in custody, whoever's holding them is obligated to provide the treatment. So under the 8th Amendment, as a guarantee against cruel and unusual punishment. And it's not a forensic lecture or anything, but I do want to mention Estelle versus Gamble. Mr. J.W. Gamble said he hurt his back working on a cotton farm in Texas while incarcerated in the state prison, and that they didn't help him. And eventually, got sent to segregation. But he was treated. He was seen multiple times, and he complained a lot. But they didn't get an X-ray. He said they didn't get an X-ray. They may have seen something. And this made it all the way to the Supreme Court. And the Supreme Court said that what he may be complaining about could be malpractice, but that's not a violation of your constitutional rights. So but they added on in the finding, like what would be a violation of constitutional rights would be being deliberately indifferent. So that's like a buzzword that a lot of offenders will write to you in some of their, I didn't get what I want, so you're deliberately indifferent to my suffering. But it would be ignoring a person's legitimate medical need. Like a person is sick and you're not getting the medical services, you're saying, well, you're malingering. I'm not going to call the doctor for you. That would be deliberately indifferent. And since being deliberately indifferent or denying a person treatment would be considered by the court as being punishment, it would link it into the 8th Amendment. So that's why under the 8th Amendment, these offenders would have a right to treatment. they have no choice in who they get to see, and authorities with custody have to provide care for their needs. Some important facts to leave you with. It's mostly males that I work with, or male institutions, but I shouldn't leave out some statistics or address some dimension of the growing female population in prison. Female inmates have almost twice the rate of mental illness. They have much higher rates of mental problems than male inmates, especially young white females. Substance use, again, is the most common psychiatric problem in all offenders. And the courts have found that the right to treatment does not include specifically drug and alcohol rehabilitation. Offenders sue. They sue under several amendments, mostly the 8th Amendment and 14th Amendment. 14th Amendment allows equal protection under the law and due process. It's an amendment that was passed so that states would not pass laws that violated a person's constitutional rights. So under Section 1983 of the U.S. Code, many offenders bring their lawsuits to get their needs addressed when they feel they're not treated fairly. And so, like, there's some outrageous lawsuits, like being served crunchy instead of smooth peanut butter. You know, they experience emotional anguish and seek damages. And that led to the Prison Litigation Reform Act, where if you get 3 frivolous lawsuits, you can't file anymore, limits filing fees to attorneys, so that cuts down on some of the enthusiasm. And they have to pay some fees to file. They have no charge for their first one, and I've seen quite a few of these. And under the Litigation Reform Act, you have to exhaust all the administrative procedures. So we try to handle it, take care of what the problem is at the lowest level before it goes to court, clogs up the court system. 8th Amendment only applies to prisoners. The person is in a pretrial detention and they get abused by the staff or something. The 8th Amendment doesn't really apply. That's something else. That's just a regular assault or just a criminal behavior. But 8th Amendment only applies to people who are convicted and in custody. You have to be convicted. You have to be a prisoner in order to be protected against cruel and unusual punishment. And that's where the right to treatment stems from. First Amendment lawsuits, that's your right to free speech and religious expression. Religious worship is a part of being in prison, or prisoners can have special allowances or privileges relate to their worshiping. And your Fourth Amendment is your right to be left alone. That's search and seizure. And, prisoners have no expectation of privacy. Oftentimes they'll ask you to see you privately, or they feel like their communications, or they want to have some privacy, and they can't because they have no expectation of privacy for the security of the facility. And I'll just go back to the objectives, make sure I covered all of them, and finish up with some questions and answers. Some other notes here, but I'm not going to get to it. I never get to everything. So we identified incarcerated persons as being vulnerable because they can't see whoever they want to, and they're entitled to health care services as a constitutional right. And we've talked about improving suicide risk assessment by looking at gaps, blind spots in our assessment techniques, and implement safe and effective care without eroding access to care in the correctional setting. That's you see people, even if they're, you have to assess them, you have to see them, even if you think that they don't need medications, or you have to follow the practices that are in place. I didn't do much in telling you about common practices unique to providing care at these facilities. We crush the meds, is one thing we do, and offenders don't like that. We have a problem with offenders hoarding medication, or not taking their medicine, or taking their medicine and selling to other people. So if a medicine can be crushed, where I work, they typically crush them. So I didn't really get to a lot of things I had set up on talking about common practices, such as the housing settings, and well, we did talk about the classification process. So instead of going into some of the other topics in this big subject, I want to address any of your questions as we finish up. And it's almost 11 o'clock, so if any of you have to go, I'm not going to hold you, but I will entertain questions if you have any. Yes, Dr. Schock.
You were would no longer cover physicians working in correctional facilities of any kind.
Yes, I have some firsthand experience with that. I didn't get that message from State Volunteer, but what they told me, I was seeking coverage in what would be Big Stone Gap area of Southwest Virginia and Pound area. It's the Wallens Ridge State Prison and Red Onion State Prison. So a volunteer, SVMIC could not cover me there. They said they would cover me for working in correctional settings, but then they wouldn't cover those areas. So I had to go to another insurance provider, and there are some special provisions in order to lower the rates or lower the risk. They want you to follow certain procedures, like having people sign consents for antipsychotic medications, and you get a certificate of coverage for the facility. I think they do that in most places, but that could be true. It is difficult to get insurance with them because it is higher risk to practice at a correctional facility because of the number of lawsuits.
Well, my question was going to be, are there any special things that you do for risk management purposes that are different from what you would have done when you were at the VA?
Yes. I make sure that I document certain things about the visit being voluntary. I have them sign a consent that goes in the chart every time. I have them sign a refusal. You'd think that I wouldn't have no-shows. The whole missed opportunity monster would be gone, but it's not. I have to go see. I will get refusals, so I have to get a signed refusal. So everything is kind of in conflict. It's like, if I didn't write it down, I must be lying about it. They wanted to go to that appointment, but I didn't want to see them. So it's a much more adversarial, or there's reason for them to do a he said, she said, or I said this, and somebody else said that. There's less openness that way. But my approach is to have them overrun my position so then I can see what's really happening. I haven't had a problem with that too much. I'm fairly safe and conservative in the approach to practice. But it's mostly the policies and procedures you have to follow, which are not that many. I have to do a lot more of the addressing grievances, whereas at the VA, that was mostly of a supervisory role, or that would get bumped up the ladder, someone else to address it. Whereas I would try to address those concerns as a consultant in the correctional setting, firsthand with the team. Any other questions? I thank you for having me today.